Welcome everyone to Cook Medical's Minimally Invasive Tympanoplasty webinar. My name is Nicole LeBlanc, Cook Medical's Otolaryngology Global Training Manager. I will be here to moderate today's session. We are so happy to have over 200 people registered for the call today from all over the world. We have two fantastic speakers to discuss their experience with minimally invasive tympanoplasty using the Biodesign Otologic Repair graft. Associate Professor Raymond No as a senior consultant otolaryngologist at National University Hospital in Singapore, and Associate Professor Jaffrey Kathubathene is a consultant in otology and skull-based surgery at 3 various hospitals in Perth, Western Australia. We would like this to be an interactive event, so I wanted to cover some ways for you to do so. First, we are going to be asking a couple of polling questions to start. This will help our presenters understand some of what the audience might already be doing for tympanoplasty procedures. You will see these appear in the top right of your screen. You may need to click the bar graph to be able to see those questions. As well, we will have the Q&A function available for you to ask questions. That is the question mark just below the bar graph. Please don't wait until the end to post questions, as there is a delay for us seeing them, and we want to make sure we answer the questions as they come in when it makes sense to do so. With that, let's welcome our two speakers, Associate Professors No and Kathubathene. Welcome.
Hi, Nicole.
Hi, Nicole.
Hi, guys. So nice to have you today. Here you'll see our disclosures for today. Both of our speakers are presenting their own clinical photographs and videos. And you will see here, we also support the Perth Temporal Bone and Otology Workshop. I'm going to pass things over to Jaffrey to introduce the Biodesign Otologic Repair graft and provide some background to the literature.
Thanks very much, Nicole. It's great to be here and to participate in this fantastic webinar and to share our experience with your audience. So the Biodesign Otologic graft is a porcine derived small intestinal submucosa, and it's an acellular matrix that's rich in glycosaminoglycans. I was actually quite surprised to find that there's actually quite a lot of research that's gone into this product, both in animal and in vitro studies, and you can see on the diagram on the video what it looks like, and we'll hopefully demonstrate a little bit more in the slides to come. The paper that first got me intrigued with this particular product was this particular study by Deredita. One of my colleagues showed it to me one day, and I read it and I was quite intrigued. So in Deredita's paper, which I think is a landmark paper in this particular field, he did over 200 cases of Biodesign. And what he found was that not only was the operative time quicker, but that it was comparable to temporalis fascia, which I think really speaks to what this graft is. That it is as hopefully as versatile as temporalis fascia, at least in my experience. There was another paper then which followed on from that by Jorn's group, and they looked at extending the use of Biodesign to patients not only with simple perforations for laryngoplasty, but also in patients with cholesteatoma surgery. And in that group, they had quite a good success rate, but they looked at combining cartilage grafting with Biodesign, and so we wanted to know how it would be in our hands with just Biodesign alone, particularly for those complex cases as well as simple laryngoplasty procedures. So I think you asked me if what the potential benefits were in adopting this in my own practice. Is that correct?
Yes, that's right.
Yeah. So some of the benefits that having read the literature, some of the potential benefits that I thought was quite important were the lack of donor site morbidity, the fact that theoretically there's unlimited graft material, and its potential use in patients where there are little or no graft options. And I think a lot of effort is spent on talking about the approach to laryngoplasty surgery and some of the intricacies of the surgical techniques. But I think more emphasis needs to be paid to what type of graft we're actually using. And so based upon that, I think Biodesign had some unique characteristics which we wanted to focus on.
Excellent. And for Raymond, what are the factors that are important in choosing Biodesign or any other graft material for that matter?
So I have been doing endoscopic ear surgery for my laryngoplasties for a while. And often when I get patients when they want for this approach, they actually request for no incisions. So I think the Biodesign fits very well into this treatment approach because potentially I can harvest the graft. I don't need to harvest the graft if I'm using the Biodesign graft, as opposed to getting it from the tragus or the temporalis. And this fits very well again to my practice because it allows me to reduce the operative time for the surgery. There are potentially some downsides though, and this I will discuss it with the patient. So for Singapore, we do have quite a lot of patients who are Muslim in religion, and they may have some concerns about the use of this graft. Some of them don't, but I do approach this topic with them and have a frank discussion on whether they find that it's something acceptable to them or something that they prefer not to use. Yeah.
Great, thank you, Raymond. Now we'd like to understand the potential use amongst Australian surgeons and case selection. So I'll pass it over to Jeffrey.
Thanks, Nicole. So we recently published this paper in the Australian Journal of Otolaryngology, and we surveyed about more than 120 Australian surgeons, and these included both specialist otologists as well as general ENT surgeons. And what we found was that the most common graft material of choice was temporalis fascia, by far and away well ahead of cartilage and perichondrium. And in terms of the actual approach, or rather placement of graft, the underlay graft technique was the most popular. And this was both in adults and in children, as well as in large perforations as well. And so this, I think this demonstrates that a material like Biodesign is quite, I think, quite an acceptable alternative to temporalis fascia, which has very similar features in terms of the amount of graft material that you can harvest. So I think this demonstrates that Biodesign certainly has a role to play in surgery. If we perhaps move on now to case selection, and in our experience, we started off with fairly simple perforations, but theoretically, any perforation can be addressed with this graft material, in my opinion. If you are starting out, I think I would choose what I call an ideal perforation. So these are small central dry perforations in a patient with a wide ear canal, with no laryngitis or tympanosclerosis or laryngosclerosis, and preferably, this is a primary case, and so you're not doing it in a revision case, and in patients where you think there's no underlying eustachian tube dysfunction. As Raymond sort of clearly mentioned, this case that you may want to embark upon are those patients that want to minimize donor site morbidity. And this may also be a consideration if the case that you're doing involves a patient where there are a lack of local graft options. So they may have had surgery, or they may have had a graft harvest before. And one other thing which I think is quite underestimated if this is a teaching case, I think Biodesign is quite suited to that, because theoretically the trainee can size the graft, and they can not quite right. They can fashion a new piece as well, and not worry about wasting precious graft material. If we start off with perhaps some of these more simple perforations, these are the ones perhaps that you may wish to start off with. So these are central perforations that may be posterior, inferior, or anterior in location. I think these are quite nicely suited to Biodesign. If you then go up a level in complexity, these are the cases that are perhaps a little bit more challenging. These are marginal perforations. They may be over the incudostapedial joint, or you may even have one perforation that you have to repair. The next level up from that are these perforations which are subtotal, and then some have some degree of inflammatory change. So or there might be some mucosal disease within the milia. Of course, these are just as challenging with any conventional graft material that you're using as well. The next, I guess, level of complexity are those patients with retraction, and then we'll come to that, I guess, in the discussion. But in terms of the handling characteristics of this graft, but if you're doing an underlay technique, and Raymond will show you his technique as well, which I think works really well in cases like these. If there's retraction, then the graft needs to be properly sized, because it's perhaps not as flexible as temporalis fascia, but certainly quite useful in this situation still, if you use it properly. And then these are the most complex cases, which I think are complex no matter what graft material you use. And these are patients with laryngosclerosis, previous surgery, greater epithelium, moist perforations, medialization of the malleus, or foreshortening of the malleus. I think these are difficult no matter what graft they use. So I think you have to take these factors into consideration when you're material like Biodesign.
Excellent. Thank you so much, Jeffrey. So I wanted to take a minute to look at our poll and see what the results are coming in like. So the first question was, what visualization method do you use for tympanoplasty? The answers were endoscope, microscope, or both. And it looks like the majority selected both, with some also just selecting microscope only. We don't have any selections of only endoscope, so it seems like most of the time people may be using both on the call today. The second question was, what approach do you use for tympanoplasty? And the answers were endural, transcanal, or post-auricular, and other. And it's an equal split between the endural and transcanal approaches. Now, not everyone has weighed in yet, and there is still time to do so. So you have time to do that. And then the last question was, what graft do you typically use for tympanoplasty? And it was an equal split between temporalis fascia and the Biodesign Otologic Repair graft. The other answers were also tragal cartilage and tragal perichondrium. But it actually looks like now more people are selecting temporalis fascia. So there you go. Maybe the majority is temporalis fascia. So you can keep going with that, and I will pass it back to Jeffrey to discuss the endural approach.
Thanks very much, Nicole. So it looks like I might be preaching to the converted as well, if some of the audience members here are familiar with the endural approach. But I'll talk through what we do in terms of the endural approach as well. Some of your audience members may not have come across this approach, so I'm glad to share how we do it. So the endural approach is our workhorse approach, and it can be used regardless of the size of perforation. Now, the incision that's made essentially is a soft tissue releasing incision that's between the tragus and the root of the. It's actually quite a small incision. I think a lot of people think it's actually a very large incision, but my endural incisions are probably about 5 millimeters, if at all. And what you do is it allows you to release essentially the meatus. And I place two self-retaining endural retractors, both 90 degrees to each other. And what that gives you is quite a nice wide field of view. And the benefits of this, of course, are the fact that you can use two hands. And it's a nice technique for use with a microscope. So you can see on the right the sort of view that you get. The benefits are if you're dealing with a case where there's some bleeding or inflammatory tissue, you can have a suction in one hand, dissecting instrument in the other hand, and if you have to deal with unexpected pathologies, both vesicular or otherwise, you can find this technique is quite useful. In terms of the closure, I think cosmetically it's a very appealing technique. Once it's healed, it's very, particularly if the incision is within the crease, and you can usually find that crease in most patients. It's very, very cosmetically appealing, and it heals. So that's my endural approach to laryngoplasty surgery. So I wanted to show you a video of a case where we use the Biodesign graft, and hopefully this will demonstrate some of the points that we've been discussing. So this is a second looked adicotomy and a cyclochain reconstructive surgery. So this patient had a cholesteatoma actually within the tympanomular flap, which had to be excised. And here we've done that, and we've exposed the middle ear and the stapes, and we're looking for recurrence within the middle ear. So you can see the head of the stapes on view there. This is an endural approach. In this patient, we decided to place a partial auricular replacement prosthesis. You can see it's in there now. But when you lay the tympanomular flap back, there is a deficit. So the flap is just too short. And this patient had surgery already, and so we naturally went to Biodesign as it served quite a useful purpose. So here we've measured the defect using a round knife or a disc elevator. And here we have the graft. So you can see this is a square-shaped graft, and you can see the size of the disc elevator. There's plenty of graft material for you to use, and I cut it with a scissors. I usually cut the corners as well, so there are no sharp edges, and you can literally shape it to however size you want. It's important to hydrate the graft just before inserting it into the patient. And so now you see the graft is hydrated, and I've used an underlay graft placement in this case. So you can see how it's a little bit more stiff, and so when you shape it appropriately, it sits very nicely, and it doesn't sort of disintegrate like temporalis fascia. You can see here I've placed it in the middle ear and laid the tympanomular flap back, and it's really important to make sure that the edges of the drum are touching the graft, because that's how visualization is going to occur. You can then place some packing in the external auditory canal. Here we're using a spongistan or gel foam with some siloxane, and that just holds the graft nicely in place. So these are the post-operative appearances. This is at day 10. On the left, you can see on the top right-hand corner the patient's on skin, and there's some spongistan or gel foam. And on the slide to the right, you can see that I've moved some of the gel foam out of the way to get a much closer view of the patient's skin graft interface. And I managed to capture this with a video otoscope, and you can actually see vascularization rather of the graft, which is a really encouraging sign, I think, in this patient to show that hopefully the graft will integrate with the skin. So that's really nice to be able to see that and show that to you.
Thank you, Jeffrey. I wanted to make sure I open it back up for some questions. We do have one to start. So to you, Jeffrey, what is the learning curve like for the Biodesign Otologic Repair graft? And a follow-up, how many cases did it take for you to get comfortable using it?
Good question. So I think for most surgeons who do routine laryngoplasty surgery, I think it's a fairly short learning curve, because essentially what you're doing is you're instead of going to temporalis fascia or to perichondrium, you literally open a packet of Biodesign and you can shape it to however you want. So I think the learning curve is short in that regard. I don't think you need to change your approach or your exposure rather. In terms of the number of cases, I think it's a difficult one. I think once you've done about 5, anywhere between 5 and 10, I think you start to get comfortable with the actual graft as well, and how it sits in your hand, how it fits in the patient, and I guess we'll talk a bit more about it hopefully later on as well. But you then you do really need to pay a lot of attention to detail in terms of how the graft sits. It's nice in that you can take it in and out of the field quite easily and reshape it. It doesn't disintegrate, but it is a little bit stiffer, and it needs to sit better. So yeah, hopefully that answers your question.
And then another question that came up: what size graft was it that you typically use?
Good question. So I guess it depends on the actual procedure that you're doing. In the video that I've showed you, that was a 2.5 by 2.5 centimeter graft. That was before Cook Medical released their pre-cut grafts, which I think Raymond will hopefully show you in his video. The benefit about that is that you can cut it to size. Sometimes I find that actually is more versatile, I think, but certainly use the pre-cut sizes as well. I prefer the 2.5 by 2.5 centimeter piece, and I can cut it to size.
Great, thank you so much. So we will now pass it over to Raymond to discuss the endoscopic ear surgery approach.
Okay, thank you, Nicole. Could I have the slides on? Yeah. So I've embarked on this approach for the last 5 to 6 years, having learned from quite a few illustrious people from Japan and Italy, Daniel Marchioni and Seiji Kakieta. So I owe my experience to them. And I was intrigued by this approach because of the visualization I got from the scope. I actually trained as a microscopic surgeon, and I hadn't used the endoscope for a while, so this took some retraining to use the endoscope again. But it's been a very rewarding journey, and I've introduced this technique to Singapore to quite a few surgeons. And actually, most of our laryngoplasties in the hospitals I work with, we primarily use the endoscope for our laryngoplasties. And our residents actually enjoy learning this technique too. Even for the senior consultants who are used to the microscope, the ability to learn a new technique and to enjoy surgery again has been quite rewarding for them. So let's talk about some of the pros and cons of this approach. As I mentioned, you really can see very well, superior visualization with the high definition scopes, and even going ahead, we can use the 4K scopes that are coming on board. Now, the scopes allow us to actually look around the corners because they give a very wide angle of view, which I'll show you all later. And this has actually reduced our need to do very little bone drilling when we do laryngoplasties, because we are able to look around corners and we're able to visualize better. But whether the instruments can get in, that will be another issue that may need to be addressed, and sometimes some drilling still needs to be done. The third point is that I am approaching the age that I'm starting to have neck problems. And it's a very common problem among otologists because of the way we use the microscopes, and we hold our head in a tilted or angled position sometimes for a very prolonged period of time without realizing it. And many of us have cervical neck problems. And just about 6 months ago, I was having paresthesia down my arm. So having the ability to do what some have called heads-up surgery, having able to keep your head straight, looking at the endoscopic view is very beneficial to us. To the patient, the benefits of the endoscopic ear approach is that they can avoid incisions and soft tissue trauma. It's interesting to note that a lot of us have moved away from the post-oral approach, and Nicole's post shows that most of us are doing an oral or endoscopic approach, which is interesting. I've always found the post-oral approach to be a lot of work, and especially you do the repair, and then you spend another half an hour trying to close the post-oral wound. So this approach actually gives us the option to reduce the soft tissue trauma. And then this leads on to the reduction in post-operative pain. Even intraoperative pain actually is reduced. Some of my anesthetic colleagues have commented that they find that the patients need a lot less sedation when we are doing this approach. There are some disadvantages. As Jeffrey mentioned, we don't have two hands to do this because one hand has to hold the endoscope. But when I thought about it, most of the time we are using the other hand to hold the suction device. So if you can control bleeding, then this is not so much of an issue anymore. And there are sort of tips and tricks to get around this, and that is the primary problem actually in endoscopic ear surgery is the learning curve to control bleeding. Some might feel that there's less depth perception with the endoscope, but the sinus surgeons have got around it, and eventually you'll get around it too when you've used it. And some people feel that the ear canal is quite a narrow space, so by the time you put a scope in, you don't really have much space for the instruments. And that was true initially when we first started this approach because we were using the 4mm scopes initially. But the technology of the scopes have improved. We use usually a 3mm scope now, and we can even use the pediatric 2.7. Although every time you reduce the size of the scope, you actually get a reduction in the quality of the visual field. So I'll bring you through a case which illustrates really well how biodesign graphs integrates in my practice. And this is basically how I sell this as an incisionless endoscopic laryngoplasty. This is a 58-year-old female, and she has had recurrent ear discharge from a perforation. The audiogram showed a 25 dB airborne gap, and she underwent an on-day laryngoplasty. And the whole procedure from the time we made the first incision to the time we told the anesthetist that they could start to wake the patient, it took 35 minutes. So as you can see, this is the left ear. She has got the central perforation. It's not a very small one. It's actually quite sizable, you can see. There are some areas of tympanic sclerotic plaques, especially in the posterior part. And so we start off by making sure our life is comfortable by controlling the bleeding. And that is the preparative phase where we inject adrenaline, anesthetic and adrenaline to the the ear canal so that we can elevate the flap with minimal bleeding. And there are many other steps that you can do too. You can ask the anesthetist to bring down the blood pressure to reduce the amount of bleeding that you would see. Now with the endoscope, everything is magnified, of course, and this looks like a lot of blood, but it's actually not that much. So here we're doing the flap incisions. We're making the axial cuts, and we're also making the contoured cuts along the tympanomedial flap that we hope to raise the flap off. And bearing in mind that we are aiming for a on-lay approach here. So here we will use a special instrument. Actually, this is a round knife, but this is a special round knife that you can see that actually there's a suction device that is integrated into the round knife. I'm using a Panetti instrument. This is developed by an Italian surgeon who also started the endoscopic ear surgery, and he developed a set of instruments that basically replaced every otologic instrument with an integrated suction in it. Very, very useful in endoscopic ear surgery. Not essential, but definitely nice to have. So this enables you to work and to remove the blood from your visual field. Here we are raising the tympanomeatal flap, and you can be very gentle because we basically aim to lift the squamous layer off the fibrous layer on the tympanic membrane. So having a patty there with some adrenaline also helps to sort of absorb the blood and make sure that our elevation is gentle, very smooth strokes, very fine strokes. You can see that we are able to visualize the fibrous layer from the inferior portion of the tympanic membrane. And here, patience is needed with the endoscope. You can't rush. If you get bleeding, you pack, you wait. There's a high temptation initially when you start off the endoscopic surgery with all this bleeding to convert to a microscopic technique when you don't feel like you have control of the bleeding. But with practice, with time, you'll find that it's manageable. So here we'll go through the perforation. You can see that we have separated the fibrous layer from the squamous layer, and we are through to the perforation. And our aim actually is to basically elevate the squamous layer off the entire tympanic membrane, leaving the fibrous layer alone, so that the fibrous layer actually can act as a sandwich that we can lay the graft on top of this fibrous layer and just replace the squamous layer. So if you get bands like this, the Bellucci scissors is helpful just to separate the bands. So this technique actually gives you the impression, it's almost as if you have put your eye into the ear canal and you're operating really close to the eardrum, and you can see with such good clarity actually. I must add that this is only the high definition scope. When we move to the 4K endoscope, you probably can see even more. So the ability to not to spend time to harvest the graft, not to have time wasted on doing the soft tissue work allows us to have more time on the actual operative field. So at this stage, it looks like we have everything up, but actually there's still a small segment at the anterior superior part of the tympanic membrane that has not been elevated. So this is something that you need to check. So we can see that the anterior superior part of the tympanic membrane still has a layer of squamous tissue, which we can then elevate with a duckbill. And this is a really ideal situation because we have the fibrous layer 360 degrees around the perforation. So if you put a graft on top, you don't even need any gel foam in the middle here actually, because the fibrous layer completely supports the graft. In this case, Cook Medical has already designed the pre-cut Biodesign grafts, and they are round in nature. There's a smaller one and a bigger one. So we use the duckbill to measure the size of the perforation so that we can select whether we choose the bigger or the smaller graft to use. They come as a set, so and the cost is a little bit cheaper than the square grafts that Jeffrey was using. And we chose the smaller one, and you can see we have already hydrated it, and basically we just plonk it on top of the perforation. And now it's a simple matter of just replacing the squamous layer over the graft. So that's why it's called a sandwich technique. Some people might describe this as a sandwich technique. Others may call this a onlay technique. This step is quite important to ensure that the entire squamous layer is properly positioned. reposition. And because we did not elevate the squamous layer of the anterior sulcus, that would prevent the formation of blunting. If you elevated the entire thing off, you might get blunting in the anterior sulcus. But in this case, we did not elevate the skin of the anterior sulcus, so there is still that angle that's preserved. And so we can see that the Biodesign graft is actually lying just below the squamous layer, but above the fibrous layer. It is really well supported. There's no place for the graft to go. And once we're happy with the position of the graft, it's just a matter of placing a couple of pieces of gel foam just to protect the graft. Okay. So this is the post-operative picture. In 1 week later, you can actually see blood vessels growing onto the graft already. And that is a very good sign because it shows that the graft is integrating very well. And this technique for me actually has been very interesting because it gives you a whole new view about otologic surgery. It allows you to see a lot more, understand a lot more, and actually it enables teaching quite well to the residents too. We find that outcomes are similar to microscopic ear surgery, and there's quite an exciting future in endoscopic ear surgery with the development of newer surgical tools and devices, potentially image guidance in ear surgery, and progression hopefully to robotic ear surgery. So there's a good future in otologic surgery. Okay, back to you, Nicole.
Thank you, Raymond. So we do have quite a few questions, so I'm going to try and direct them to each of you. The first one is for you, Raymond. So regarding the endoscopic approach, some U.S. surgeons advocate a standing position for endoscopic ear surgery, which may allow better natural ergonomics to access the hypotympanum. What is your opinion on this?
Yeah, I've seen surgeons who stand up. I've seen surgeons who sit down. I think it's just a preference. There are surgeons who also work on the opposite side of the patients so that they can see better into the retrofacial recess. I think you have to be adaptable. For me, actually, one of the reasons why I chose otologic surgery is I wanted to sit down to operate. So I prefer to sit down, and also it allows me to rest my arms to get a more stable view with the endoscope. So I think it's a surgeon preference. There isn't a right way or a wrong way to do it.
Excellent. Thank you. And a follow-up question for you, Raymond. What size endoscope do you recommend? Does it reduce time for surgery using the endoscope?
Yes, I think it definitely does. Okay, let me answer the first question first. I think the ideal sort of the best of both worlds is the 3mm endoscope. The reason why the 4mm endoscope gives a really, really nice view, but it's kind of too big. And you'll find that your instruments will start to fight in the ear canal. So the 3 I find is the best. And the 3 gives enough stiffness that the scope doesn't bend. The problem with the finer scopes, the pediatric ones, is they bend very easily, the 2.7. So I find that 3mm for me is the sweet spot. But if I find a patient's ear canal is quite wide, and I would like better visualization, I will go on to the 4mm endoscope. Now, the second part was?
The second part, sorry, does it reduce time for surgery?
Oh, yeah, okay. Yes and no. In the beginning, it might seem a bit slower because it's a new technique to you. But for us, actually, I find that it reduces because we don't have to harvest the graft. We don't have to do the soft tissue approach and the repair. So compared to the traditional techniques, we have found that it reduces the time. The setup is not very long, and I think definitely compared to the post-op approach, there's a lot of time saving. But Jeffrey's technique, the NRO, actually is quite fast too. So You just have to see for yourself, I guess. Yeah.
And one for you, Dr. Jaffrey. What are some of the complications with the endural approach?
Complications. That's a bit of a tricky question. It's almost a leading question in a way. I don't. I mean, it's as with any laryngoplasty surgery. I think I don't alter the consent process with when I'm telling patients about this particular approach. Sometimes I think if you don't close the endural incision appropriately, you can get a bit of a gap in the wound, and then it just slows the healing process down. So I think that needs to be mentioned. And sometimes you can, if you haven't used this technique, you can get quite overzealous in almost over closing the meatus, and you can make it smaller. But I think that's but I think if you use the endural technique quite regularly, I think it's a very nice technique, and certainly, as Raymond mentioned, I would much prefer that to the post-auricular technique. I think there's a lot more soft tissue work. I think you disrupt some of the ligaments around the ear, ensuring that the meatus is placed over the ear canal is important in the post-auricular approach, whereas in the endural approach, you don't have those concerns. The endural approach also allows you to perform a soft tissue meatoplasty if you wanted to as well. So to make it easier for you to visualize the drum to surgery. So I think those are some of the pros and cons.
Great, thank you. I want to move on to talk about postoperative management of these cases. And Raymond, maybe you can go first and just discuss how you manage these patients postoperatively.
Okay, so I don't give patients any antibiotics immediately after the surgery. They just get some simple analgesics, which they rarely take anyway because they say they don't have much pain. And I usually bring them back 1 week later. And if there's any loose gel foam, I would remove it on that visit. But if there's gel foam that's stuck, that's adherent to the graft, I usually would leave it alone. The next visit may be a week later or maybe 4 weeks later, depending on how I find the condition of the ear canal. If it's quite clean, I'll bring them back 4 weeks later. But if they do require some ear toilet, if there are any concerns, then I'll see them on a more regular basis first before I put them into a longer interval. But in general, I don't give eardrop antibiotics because there's some concern that a lot of the eardrops contain steroids. And the ofloxacin eardrops or the ciprofloxacin eardrops do have fibroblast inhibiting factors as a problem with these antibiotics. So I try to avoid them unless there's no choice. There's a frank infection that needs to be treated. So if I use eardrops, it will be just the antibiotic without the steroids. Yeah. What about you, Jeffrey?
Jeffrey?
So I'm very similar. I see them at 2 weeks post-operative. I suction some of the gel foam packing that's in the ear, but I leave most of it in there. And I warn patients that, to expect that the ear will be blocked, then they hear some popping, cracking sounds, and all that's fairly normal. I don't give them post-operative drops unless the ear looks inflamed or affected. And then I see them back usually about 6 to 8 weeks later, where I then do an audiogram if the graft is integrated nicely and the middle is aerated. I have to say I tend to use ciprofloxacin soaked gel foam as packing in the external auditory canal, and I have to say I haven't found it to be a problem so far, at least in my practice. So that's perhaps the only difference.
Perfect. And there is a question that came up, and either of you can answer it. Do you find that there's a more rigorous inflammatory response with the Biodesign graft compared to temporalis fascia?
Yeah, maybe I'll take that. It can be. I find it quite variable. There are some patients where the graft looks pretty good, in the first week. But I've had a few patients who do seem to have a reaction, a kind of florid reaction. Maybe that's what the question was alluding to. But the recommendation is that sometimes the graft looks quite edematous. So it's best to kind of leave it alone rather than to manipulate the graft. So that's what I've been doing. Yeah.
Any comments from you,
Yeah,
Jeffrey?
I was going to say, look, I found the same as well. I don't think it happens in every patient, but in some patients, I do see that, and you kind of have to just hang on for the ride and just trust that that the graft is positioned well, and that the healing process will continue for the positive. But it can be a little bit disconcerting when you see that. But I think it's part of the the inflammatory process, and I guess inflammation to some degree is a good thing, and that's what kickstarts the healing process, particularly in a really scarred or tympanosclerotic ear where the inflammatory process has essentially stopped. So I don't think it's necessarily a bad thing, but it's something just to
Great, thank you. So we want to talk a little bit about outcomes. So Jeffrey, do you mind going through what one can expect with regards to outcomes using the Biodesign Otologic Repair graft?
Sure. So I'd like to share with you some of our results. This is currently under review in a peer-reviewed publication. So we hope to have this published very soon. This is our initial experience between myself and one of my colleagues, who's a pediatric otolaryngologist, and we wanted to look at closure rate and otological outcomes in our group of patients. So just to give you a bit of background about our technique, so this is an underlay graft technique. All the cases were performed under general anesthesia. And essentially, we used Biodesign in place of what we would conventionally use for any particular case, so either temporalis fascia, perichondrium, or cartilage. We did use gel foam packing in the middle ear. And in this series, and this was early in our experience, we actually used kenochrome ointment in the external auditory canal, which I think may have influenced some of our results because according to the Cook medical engineers, I believe that kenochrome real-based ointment that may interfere with integration of dealing with the matrix of the graft. We've since stopped using that. The graft material was leptosulk and saline in patients, and I believe that the advice now has changed, and that you just hydrated just before graft insertion. And we also used kenochrome ointment and xeroform packing in the ear. When we did this, when we started using this, the 2.5 by 2.5 centimeter graft was what was available at the time. We had 35 cases, and we looked at both simple laryngoplasty as well as complex cases. So these are cases that involve surgery type procedures. In our simple laryngoplasty group, we had an age range from between 5 to 63 years of age, and so we included pediatric patients in this group. And in the complex group, a similar sort of mean age to the simple laryngoplasty group, and a slightly older cohort as well. In both cases, both patient groups had a similar conductive hearing losses with a similar bone gap. And we measured this across 4 frequencies. And you can see the spread of conductive hearing losses in the group. So in some patients with small airborne gaps and some with much larger ones. The mean size of the simple laryngoplasty group was about 36%, but we had patients that had small perforations all the way through to patients that had subtotal perforations. The majority were primary cases, and 3 cases, during which the case was the second attempt. There was an even split between transcanal and endural, and we had to perform 3 canalplasties to gain access in this group. The location of the perforation varied quite a lot. Most of them were inferior, but there was quite a spread of locations. So they weren't just in the one location. In the complex group, we had 5 patients that had primary surgery and 4 had revision surgery, and 7 cases we performed the androlar approach and 2 a post-auricular. And you can see the type of surgeries that these were performed. The predominant cases that we used them for were for adicotomy type procedures, but we also used it in patients where we performed second look procedures, or in patients where we used it reconstruction of the modified radical mastectomy cavity, which I think is quite a versatile option in these patients. The closure rate for the simple laryngoplasty group overall was 73%, and this is a mean follow-up of just up to over 6 months and ranged up to 2 years. There was no statistical effect on age on closure rate. We included there were some patients, a couple of patients, particularly pediatric patients, where we couldn't visually see the entire graft, particularly where the perforation was, but because they were obviously they wouldn't tolerate ear suctioning. But in these patients, they had a normal tympanogram and audiogram, and so we assumed that their graft had healed. In the complex cases, we had a mean follow-up of 48 days, but up to 3 months, and we had about a 78% closure rate. And so I think this graft works quite well in this particular group. In one patient, again, due to intolerance to suctioning, we couldn't see the entire graft, but certainly the majority of the graft had actually taken quite nicely. In terms of postoperative hearing outcomes, in both groups, there was a significant improvement in hearing, as demonstrated by a reduction in the air bone gap. And this is both in the simple laryngoplasty group as well as in the case group as well. Over to you, Raymond.
Yeah, hi. So I work at 2 hospitals, so I was interested to find out what was the success rate with the biodesign grafts were. So what I did was basically I did a very simple audit. Unlike Jeffrey's study, we didn't actually analyze the data. All I just wanted to know was, based on the graph that was used, what was the success rate like? If you could show the slide, yeah. So we can see that the spread of the type of the grafts are quite even between the trachopericondylar temporalis fascia and the biodesign. And we find that the success rates are quite similar. The trago and the temporalis can range from about 80 to 85, 88%. And the biodesign was about 77, 71%. But when we ran it through the statistical analysis, whether these differences were significant on both sides, they were found to be not significant. So the biodesign does appear to have a slightly inferior result compared to the trachopericondylar and the temporalis. And so when we consent our patients for surgery, we do tell them about this difference. As this is part of the consent process. Yeah, thank you, Nicole. Yeah.
Great, thank you so much. So the rest is we're going to try and work through a number of questions that have come up in the portal. So I'll try and direct them at one or another of you, or some of them are not necessarily directed, but I'll do my best. So we'll go back to Raymond. The onlay technique, also called the sandwich, do you refresh the edges of the perforation before raising the flap?
No, we don't, because when you raise the squamous layer off the fibrous layer, you are essentially freshening that edge. So we do not re-perforate, do that stamping technique where we rim the perforation. So sometimes when you do that, you find that your fibrous layer gets very, very small. So no, there's no necessity to rim the perforation with the onlay technique.
Excellent. And then as a follow-up, is it often as straightforward raising the squamous layer from the fibrous layer as you do show in the video?
Yeah, I must say that was an ideal case. It's not always the case that this layer comes off very easily. So sometimes, yes, we do convert to an underlay when we find we can't do the onlay technique. The other thing is sometimes you think there's a fibrous layer underneath that, but when you raise it off, you find that there's actually a large deficient area of fibrous layer. So it can still be done, but there are times we do convert back to the underlay technique.
Thank you. For Jeffrey, is there any cases that you've had reabsorption of Biodesign that was too fast? Have you experienced that? Or actually, I can ask Raymond too. Have either of you experienced that?
Not that I can recall. I think, look, there's with any graft material that you use, there's always going to be some degree of failure, even with perichondrium or temporalis fascia. And whether that is resorption of the graft, I'm not sure. I think it's more likely a wound healing, local, sort of factors that determine whether a graft gets integrated or not. The presence of absence of any infection, scarring that's in the middle ear, that's in the membrane. So I don't think that then leads to resorption of the graft. I think maybe that's what the question is getting at. I think it's more just to do with wound healing, and I think that's always going to be a challenge with no matter what graft material that you use.
Raymond, anything additional from you on that?
I don't think there's a difference. My impression is there isn't a difference between the types of graft we use. More importantly is what is the cause of the failure. I think if there's infection, no matter what's in there, it's likely to disappear quite quickly.
Thank you. So there's a couple questions around handling. And I'd like both of you to answer this just in terms of your experience. So describe the handling characteristics of the graft. Is it easy to work with? And are there any instances where you don't hydrate the graft?
Shall I go first?
Yeah,
Sure.
Go ahead.
So the graft is actually a little bit thicker than perichondrium and temporalis fascia, and so. But sometimes perichondrium can be a lot thicker, and so that gives some stiffness to the actual graft, which I think is there's pros and cons to it. I think it's a good thing because you can place it in the field. If you don't like the way it sits, you can take it out, you can put it back in again. Even though the field is very moist, the graft will retain its shape, and you can. Even if it's moist, you can actually. I've taken it out before. If I'm not happy with it, and I cut it to size even when it's moist. So I think that's probably the main thing, but perhaps it's less able to conform to the surrounding structure. So you have to almost cut it to shape really well, rather than rely on the graft stretching or being pliable when it becomes wet, like you would with temporalis fascia or perichondrium.
Yeah, I agree with most points that Jeffrey mentioned. I think the graft definitely handles differently from the temporalis fascia, especially, maybe more like perichondrium. The thickness is something that you need to get used to. Ideally, I would have liked the Biodesign graft to be thinner, actually, and to be more pliable. But it works both ways, I guess. Having it more stiff allows you to manipulate the graft better, actually. I find it's stiffer, so you can actually move the graft easier. But that works against you when the surfaces don't conform very well to the graft. With the temporalis fascia, sometimes when you find that you need to remove the graft, you need to re-dry the whole thing and you need to set it again, and that takes time. With the Biodesign, you can take out the graft, soak it, put it back in quite easily. You don't really have to dry at the graft again because of the stiffness of the graft in its natural form. Yeah, so I don't really think I've that much problems with the handling. I don't really think there's a learning curve to it once you understand the characteristics of it. Yeah.
And there's another question for you specifically around how do you sharpen your endoscopic instruments?
Sharpen.
Do you sharpen your endoscopic instruments? I guess.
No, I don't. I don't sharpen them. I don't put them to mortar. If they get blunt, we buy new ones. Yeah.
Yeah. I think there was also a question, Nicole, about the about whether you would put it in dry. So I think I would. Oh, can you hear me? Yeah.
Yeah. I
think maybe there are some instances where I may put it in dry if the field is very moist. But I think by and large, as Raymond mentioned, you can soak it, you can take it out, and it's still going to keep its shape. So, so maybe in some instances, if it's a really moist field, you would put it in dry. But otherwise, you want some degree of pliability when you put it into the ear.
Yeah. Yeah, if I could add, I don't think there's a need to put it in dry because of the stiffness. It's not like temporalis fascia where you do like it to be a little bit dry initially when you insert the graft. So that's the advantage of the stiffness of the biodesign. Yeah.
Great. So we're out of time, but there's one last question on the portal here about is there a need to estimate mastoid air cell before the operation? And I'm not even sure what they're asking there, but can one of you address that?
Sure. Okay. I guess this pertains to the question that the mastoid air cells contributes to the middle ear volume. So there's this school of thought that if you have a very sclerotic mastoid, that makes the graft more likely to fail because the middle ear pressure, due to the small amount of volume, can change quite drastically. So actually, there's a school of thought that some people would, especially for revision laryngoplasties, would add a cortical mastoidectomy, open up the facial recess to improve that middle ear volume, to improve the success rate of the laryngoplasty. I think the jury is still out there as to whether that really makes a difference. Based on my experience, I haven't really found that to be the case. I found that the eustachian tube function to be more important than the mastoid air cells. So that's been something I've been trying to address with the eustachian tube dilation techniques. But I'm still in the preliminary phase. I don't really have much evidence that works anyway too. What about you, Jeffrey?
Yeah, look, it's I used to do that very early on in my practice and subscribe to that. To that idea of doing a cortical mastoid if a patient came in for a revision surgery. I don't think there's really much evidence to that. I think the issue is not in the mastoid. I think the issue is in the middle ear. And nowadays, I actually spend quite a bit of time addressing the mucosa in the middle ear. Making sure that it's free of any disease. Opening up any scar bands that may be present, that may be perhaps affecting the aeration of the middle ear. I know the endoscopic surgeons are very much for that, and that's something I support. And you can certainly do that via the indoor approach as well. So I think that's more important than doing a cortical mastoid.
Thank you so much. And we're out of time here, so I will wrap things up by saying thank you to our speakers. Thank you to everyone who attended today. We really do appreciate it, and we hope that you have a wonderful rest of your evening or day, depending on where you're calling in from. Thanks again.
Thanks, Nicole. Thanks for having us.
Thanks.